Pulmonary hemorrhage is the acute presence of blood within the alveoli of a newborn's lungs, usually resulting from rupture of the alveolar-capillary interface. It leads to sudden respiratory compromise characterized by hypoxemia, reduced lung compliance, and impaired gas exchange. This condition is most often seen in extremely preterm infants due to fragile pulmonary vasculature, but it can occur in any neonate exposed to risk factors that increase pulmonary blood flow, compromise vascular integrity, or trigger sudden changes in alveolar pressures. Clinically, pulmonary hemorrhage is identified by bloody secretions in the endotracheal tube or airway, sudden deterioration in oxygenation, and increased ventilatory requirements. Pulmonary hemorrhage is rare overall, affecting about 0.5% of neonates, but the incidence rises sharply in extremely preterm infants, reaching nearly 9% at 24 weeks gestation. The condition is strongly linked to patent ductus arteriosus, surfactant therapy, and perinatal asphyxia, each of which contributes to sudden increases in pulmonary blood flow or compromises vascular integrity, making fragile alveolar capillary networks more susceptible to rupture. Mortality is extremely high. Approximately 41% of affected infants die within the first 7 days, 54% within 30 days, and 57% before hospital discharge. These outcomes highlight both the severity of the insult and the vulnerability of preterm lungs. Survivors frequently experience recurrent pulmonary morbidity, including chronic lung disease, and may be at risk for long-term neurodevelopmental impairment, emphasizing the need for rapid recognition and aggressive supportive management. Pulmonary hemorrhage occurs when the delicate alveolar-capillary interface ruptures, allowing blood to flood the alveoli and rapidly impair gas exchange. One primary mechanism involves patent ductus arteriosus. Left-to-right shunting increases pulmonary blood flow, engorging capillaries and predisposing them to rupture. Surfactant therapy can contribute indirectly. When surfactant lowers alveolar surface tension, lung compliance improves suddenly, increasing blood flow through the pulmonary microvasculature. In extremely preterm lungs, these vessels are fragile, and the abrupt hemodynamic shift can precipitate alveolar bleeding. Asphyxia, hypoxia, and acidosis further compromise vascular integrity, weakening capillary walls and making them more susceptible to rupture under even modest pressure changes. These overlapping mechanisms explain why pulmonary hemorrhage often appears suddenly in critically ill preterm infants and why it is frequently associated with PDA, surfactant administration, or perinatal stress. Pulmonary hemorrhage typically presents with sudden and severe hypoxemia, reflecting rapid flooding of alveoli with blood and impaired gas exchange. The hallmark sign is bloody endotracheal secretions, which provides an immediate clinical clue to the diagnosis. Infants often show a sudden increase in ventilatory requirements as compliance drops and oxygenation deteriorates. This may be accompanied by hemodynamic instability, including hypotension or poor perfusion due to hypoxemia and associated stress on the cardiovascular system. Recognizing these signs early is critical, as pulmonary hemorrhage can progress rapidly, leading to life-threatening respiratory failure. Monitoring for abrupt changes in oxygenation, lung compliance, and airway secretions allows timely intervention to stabilize the infant. Pulmonary hemorrhage is diagnosed primarily through clinical observation, with the most specific finding being bloody endotracheal secretions. These secretions reflect alveolar capillary rupture and are accompanied by a sudden, severe drop in oxygenation and rapid deterioration of ventilatory parameters. Pulmonary compliance falls abruptly because alveoli are filled with blood, reducing effective tidal volume and increasing airway pressures. Chest radiography is a critical adjunct. Early on, infiltrates may be subtle, but with progressive bleeding, the lungs demonstrate diffuse bilateral alveolar opacities. In massive hemorrhage, the classic whiteout appearance indicates nearly complete alveolar flooding. Radiographs help distinguish pulmonary hemorrhage from conditions like respiratory distress syndrome or bronchopulmonary dysplasia exacerbations, although overlap can make differentiation challenging. The differential diagnosis must include pulmonary edema, where fluid rather than blood fills alveoli, pneumonia, which produces focal or patchy consolidation, aspiration, which can mimic alveolar infiltrates, and traumatic airway bleeding from intubation or suctioning. Adjunctive evaluations are essential to clarify underlying contributors. A complete blood count, coagulation profile, and platelet count help identify coagulopathy that may exacerbate bleeding. Review of recent airway manipulations ensures that observed blood is not iatrogenic. Integrating these assessments allows for rapid recognition of pulmonary hemorrhage and guides timely stabilization and management strategies, reducing the risk of prolonged hypoxemia and multi-organ compromise. Management of pulmonary hemorrhage begins with airway stabilization and oxygenation. The infant should receive 100% oxygen if needed to correct hypoxemia, and the airway must be secured to allow effective ventilation and suctioning of bloody secretions. Perfusion support is critical, as sudden alveolar flooding and hypoxemia often precipitate hemodynamic instability. Intravenous fluids and, if necessary, vasopressors maintain systemic blood pressure and organ perfusion. Coagulopathy must be corrected promptly. Platelet transfusions restore hemostasis in thrombocytopenic infants, fresh frozen plasma addresses clotting factor deficiencies, and vitamin K supports gamma carboxylation of clotting factors. Ventilatory strategies aim to minimize further lung injury while optimizing oxygenation. High-frequency oscillatory ventilation, HFOV, is often preferred because it delivers small tidal volumes at high rates, limiting alveolar overdistension and further bleeding. Conventional ventilation may be used with higher positive end expiratory pressure, PEEP, to tamponade alveolar bleeding, but careful monitoring is required to avoid volutrauma. Pharmacologic interventions can be applied for acute hemorrhage. Epinephrine instillation via the endotracheal tube in a 0.5 to 1 milliliter dose of 1 to 10,000 solution may help control bleeding by vasoconstriction. Surfactant replacement can improve oxygenation once the hemorrhage is stabilized, although it may transiently increase bleeding risk if administered too early. Finally, underlying causes must be addressed. Management of patent ductus arteriosus through medical or surgical closure can reduce excessive pulmonary blood flow. Any associated systemic illness, such as asphyxia, sepsis, or coagulopathy, must also be treated to prevent recurrent hemorrhage and stabilize the infant's overall condition. Pulmonary hemorrhage carries a mortality rate significantly higher than in neonates without hemorrhage, with most deaths occurring within the first 7 days. The severity of the bleed, gestational age, and presence of comorbidities such as patent ductus arteriosus, asphyxia, or sepsis strongly influence survival. Survivors often face recurrent pulmonary morbidity, including chronic lung disease or bronchopulmonary dysplasia, due to repeated alveolar injury and inflammation. Long-term consequences may include neurodevelopmental impairment, particularly in extremely preterm infants whose lungs and brains are both vulnerable to hypoxemia and systemic stress. Outcomes improve with rapid recognition, aggressive ventilatory support, correction of coagulopathy, and treatment of underlying causes. But even with optimal care, pulmonary hemorrhage remains a life-threatening complication in the most fragile neonates. Pulmonary hemorrhage is an acute, life-threatening event in which blood floods the alveoli, resulting in rapid respiratory compromise. It occurs most frequently in extremely preterm infants, whose fragile pulmonary vasculature makes them highly susceptible. The condition is strongly associated with patent ductus arteriosus, surfactant therapy, and perinatal asphyxia, all of which can increase pulmonary blood flow or impair vascular integrity. Clinically, pulmonary hemorrhage presents with sudden hypoxemia, rising ventilatory requirements, and the hallmark sign of bloody secretions in the endotracheal tube. Chest radiographs typically show diffuse alveolar infiltrates, and in massive hemorrhage, a whiteout appearance may be observed. It is critical to rule out coagulopathy or traumatic airway injury to confirm the diagnosis. Management begins with airway stabilization and oxygen therapy, along with support of perfusion and blood pressure through fluids and vasopressors. Correction of any underlying coagulopathy is essential, and ventilatory strategies such as high-frequency oscillatory ventilation or conventional ventilation with higher PEEP are used to limit further alveolar injury and support oxygenation. Pharmacologic interventions, including epinephrine instillation via the endotracheal tube and surfactant replacement, can be applied after stabilization. Addressing underlying contributors such as PDA or systemic illness is also critical. Despite optimal care, mortality remains high, approximately 50% or greater, and survivors are at risk for chronic lung disease and neurodevelopmental impairment, reflecting the severity of the insult and the vulnerability of the preterm lung.